Ladies and gentlemen, it gives me great pleasure to say that I can now welcome you today. Shh, aim in my direction, thank you. Good morning. My name's Julie McCrossin and it's my enormous pleasure to be the MC this morning. This is the fourth in the series of national health reform discussions here at the ANU and of course supported by the Australian Primary Healthcare Research Institute and the Menzies Centre for Health Policy. Our topic today, and it couldn't be hotter if you're watching telly or listening to the radio or on the web, is youth mental health. Is anybody listening? Could you clap just because we're here? I'd like to welcome our panel. I'll ask them to wave if you would as I introduce you. I'd first like to welcome Professor Patrick McGorry, AO, Australian of the Year of course, Executive Director of Origin Youth Health at the University of Melbourne and a founding board member of Headspace and a passionate advocate doing great advocacy for mental health and youth mental health. Would you please make Patrick McGorry welcome? Welcome also to Professor Ian Hickie AM, another great advocate, Executive Director of the Brain and Mind Research Institute at the University of Sydney, a founding board member of Headspace and inaugural CEO of Beyond Blue, and another man who I think utilises the media very effectively. Please welcome Ian Hickie. It's my pleasure to welcome for the second time on a panel here at the ANU that I've facilitated Professor Helen Christensen, Director of the Centre for Mental Health Research here at the ANU, a Senior Principal Research Fellow with the NH&MRC, and someone with a real passion for research and evidence-based services. Please welcome Helen. It seems odd to welcome our host. He's really welcoming me, but welcome to Robert Wells, the Director of the Australian Primary Healthcare Research Institute and Menzies Centre for Health Policy here at the ANU, and former First Assistant Secretary with the Department of Health and Ageing. Please welcome Robert Wells. And also welcome to Carla Frost, a consumer advocate with Origin Youth Health and a university student at RMIT where she's studying social work and psychology, and she's a consumer advocate representing a consumer voice here today. So please welcome Carla. Now, I'm going to start with Carla because I'm sure we're about to explode into the immediacy of our advocacy as part of the federal election, as we should. But it's so easy to lose sight of the individual and families who are so directly and deeply affected by the issues we're discussing today. So Carla's kindly agreed not only to talk about her work as a consumer advocate with the platform team at Origin Youth Health, but also a little about her personal experience. Do you mind just giving us a sense of what you've faced in your own challenge with mental health?
Yeah, most definitely. I first became unwell when I was doing my final year of VCA. I guess I wasn't really sure what was going on at the time, but it concerned me enough and I just felt different. And I guess it was for that reason that I took myself along to a GP just to get checked out. Luckily at the time I had a really good GP who took me very seriously and then took it upon herself to contact Origin Youth Health. I guess I'm always pretty grateful to that GP because I think perhaps had she had not taken me seriously or acted on her suspicions, then perhaps I would never have taken the initiative to seek help again. From there, I went through, obviously a series of assessments and was admitted to Origin Youth Health, where I spent sort of the next 3 years receiving a variety of treatments.
What helped you the most? If you could just tip it up a bit, it's like, if you could look at it like that, thank you. What helped you the most?
I guess being able to go to a youth service was the main thing for me. Sorry.
The key to mental health advocacy is microphone technique.
Hopefully I've mastered it. I guess going to a youth service was great for me. It was my first experience with the mental health system. It was scary enough as it was. I was feeling isolated as if I was the only young person feeling these things. And then to be able to go into a service where there were sort of hundreds of other people in similar situations, whether they were studying or out of work or whatever, all going through the same struggles, and just being able to relate and see that, yeah, people do get better and treatment is out there.
We spoke briefly before coming in this morning, and Carla has some key points, so I thought we'd give you the opportunity to speak to them now. You talked about help seeking and your GP helping you with that, and that's one of your key messages, to promote help seeking. What do you mean, and what needs to be done?
I think when you're a young person, you're going through all these changes, and you're not sure whether all these changes are just because you're a young person struggling with school, and if these things are normal or if they're not. And I think I'd encourage every young person sort of just to go and get them checked out just in case. And yeah, I don't think there's anything wrong with seeking help. Everyone needs to ask for help occasionally, and to get help early just means a quicker recovery, really.
This early intervention, you hear it all the time, but what does it mean and why does it matter?
Early intervention for me is sort of treating the problem as it arises or just after it arises. It just makes sense to me. There's no point struggling along for a few years and just watching yourself get worse and worse. If you go and get help quickly, you get better quickly and you can just resume normal life.
And your key message is the need for youth-specific services. What does that mean and why do we need it?
Yeah, youth-specific services is something I'm actually really passionate about. Having been treated in a youth-specific service, obviously Origin, I just know how much that system worked for me. I think young people have different needs to perhaps the adult service, and to have a service that's youth-friendly, not only in appearance but also treatment method. And
what does that mean, youth-friendly? I'm 55, this is beyond my imagination.
Well, I think if you walked into Origin, you'd just straight away see the difference between a youth service and an adult service. You walk into Origin, there's hundreds of young people just sort of hanging around. It's informal. It provides a range of treatments that are specific to young people, whether this be sort of re-engaging in education or vocational work. And I think the priorities of young people are a little bit different to adult.
Before we move on to the sort of hot politics of the day, you're a member of a platform team at Origin Youth Health. What does that mean?
Yeah, the platform team's a pretty exciting group of young people down at Origin. At the moment, it's made up of about 10 young people who are either present or past clients of the service. And basically we work as the consumer model of the adult service. This means that we meet sort of once a fortnight in our own little platform team room, and we discuss sort of any current issues that have been brought up. This agenda is usually driven by young people at Origin, so whether it be the platform team itself or things we've noticed around the place that other clients have passed on to us. And we then sort of work to make some really positive changes around service and service development, and then pass that on to management.
I see, so you're really part of governance at the youth service that you're talking about. And also, is this kind of work part of what you do as well?
Yeah, we do a range of activities, around decision making, around sort of promoting positive mental health, consulting with services, and even sort of other things around Origin, such as sitting on staff selection panels and running a peer support program.
I'll just come to Melissa Thurley. Where's Melissa? I might come over here. Melissa is Youth Participation Coordinator at Origin Youth Health. What do you think is the key reason why having consumers active in the service is important?
I guess because the young people who have come through the service are essentially the experts on what it's like to be a young person with mental health difficulties, who can give us some great feedback based on their own experiences moving through the service, what we're getting right, what we're getting wrong, providing them with the opportunity for input into service development and delivery.
And do you do media training to help people like Carla cope with this?
We do. We've got a fantastic media relations woman who provides training to all our peer support workers and platformers.
I ask that because our theme today is youth mental health. Is anybody listening? And in my experience, politicians, and they're the ones we're going to talk about in a moment, we're desperate for them to listen, will often listen more to an individual directly affected than a bunch of these professors. These professors will never shut up.
I think the platform team all have amazing stories about what they've been through, really powerful stories, really upsetting stories, and people do listen to them because they are the voice of what's happening for our youth.
Look, Thank you so much. Would you please give Melissa a round of applause, and also Carla. When I come into the audience, I will hold the microphone, but we're going to have regular opportunities for questions and comments. I'll ask Carla to pass the microphone to Patrick McGorry. Patrick McGorry, of course, the Executive Director of Origin Youth Health. I heard you on PM last night. Today is fundamentally about our key concerns when it comes to services for young people, what needs to be done, and the political mechanism for delivering it. On PM last night, you were quite critical of the announcement made by our Prime Minister, Julia Gillard, and Nicola Roxon, the Health Minister, yesterday in relation to suicide prevention. What was announced yesterday, and why are you critical?
Well, what was announced yesterday was one brick in a big wall, the suicide prevention part, and a few other very small announcements alongside it. But there is a huge wall to build, and what we have to build, for reference today, is actually a huge gap in the system, the youth focus, which Carla was speaking about. And you're quite right, the politicians do listen to the young people. Tony Abbott came to visit Origin probably about 5 or 6 years ago, and he listened to Carla, might have been there, or other young people at the time, and he took a lot more notice of them than as you say, professors that talk all the time.
Is part then of what we need to do to give more people like Carla the support and training and skills to be public spokespeople?
Absolutely, but I think we have to work together. We're putting up plans to government. We have put up a very comprehensive plan based on the Health and Hospital Reform Commission recommendations and signed off by the Mental Health Council of Australia, plus 70 other organisations. And it's been completely ignored, you know, and a series of other recommendations have been put up which really don't go to the heart of what's needed.
I want to hear from you the guts of what that blueprint involves for young people, and what you said when you had a meeting directly with Julia Gillard about it. But first of all, why is it being ignored? What's happening politically at the moment?
That's a very, very good question. I don't know if I've got the answer to that. I think that politicians have been I suppose, immunised against action in this area because of stigma and because we haven't had these sort of forums and this level of debate in mental health until very recently. So I think the community is way ahead of our political leaders. Now, as you can see at the moment, there's a big differential between the two parties in terms of what's on offer at this election. So I think the government has got a lot of catching up to do. They got themselves into a big mess over COAG, where mental health was completely left out of the equation, and they're scrambling to catch up. And what we saw yesterday was a scramble to catch up, and it's not really focused on what's needed. It's one part of it, but the scale is the major problem. It's so way off scale in terms of the investment level that's required.
John Mendoza is quoted in today's press as saying it's a scattergun approach that will not really change the fundamentals, and that while the suicide prevention package is useful, it's not mental health reform. Do you essentially agree with that?
Yeah, very much so. I think we had a Health and Hospitals Reform Commission process which forensically looked at all the evidence in mental health. It came up with a series of 12 recommendations. There are a few other things that we could probably say should be added to that list, including research, but that was the most rigorous process we have. The government said it would follow those recommendations. It hasn't done so yet. Now, Julia Gillard said a second-term agenda for mental health, but you can't have a second-term agenda without the financing of that second-term agenda, which has to be put into the forward estimates.
I'll come back to the politics in a moment, but what did you say to Julia Gillard was essential for youth services when you had that chance to speak to her directly?
Yeah, and she gave us a very good hearing. I think she does understand mental health reform. But what we said was, basically, we have got the building blocks in Australia now with Headspace and the early psychosis model, which is expanded now into Origin. There's a broader spectrum early psychosis model now. But those are the unique building blocks which Australia has. No other country has those. But we're being so timid in growing those. We could scale those up across the country within the next 3 years in a very dramatic way. That's what we said to her. We also said, you've got to clean up the mess after deinstitutionalisation. All these poor people left languishing all around the country. The horror stories I hear every day of the week from all around this country, from people who've been left behind by the failures of deinstitutionalisation. That's another huge job, a mopping up job.
you mentioned their Headspace and early psychosis services. I know we have many very sophisticated people in this room, and I'll come to you for what you think are the priorities shortly. But just for our web audience and perhaps some students who may be here, in a nutshell, what's Headspace and what is that early psychosis service?
Okay, Headspace is along the lines of what Carla was saying, the enhanced primary care process. I usually use the analogy of the iPhone, the one-stop shop where all the things that you need, the applications that you need are in one place. The young person can walk into this youth-friendly primary care environment and see a GP like Carla described, plus backup from allied health professionals, vocational experts, and drug and alcohol people, and then connection to a network of other services. So that's what the ideal Headspace is. It's working extremely well, but it's under-financed at the moment. Linked to that, you need the backup system of a specialist youth mental health service. We call it EPIC, which is the psychosis focus, because that's where the most evidence is in support of early intervention for psychosis. But there are other serious disorders that a youth specialist service as a backup system will need to cover too. So those two linked programs will build a stream of care in that zone, 12 to 25, where the most onsets and new cases actually do occur.
In today's Australian, Chris Tanti, the Chief Executive of Headspace, is saying there's just not enough money, some services may close. You're quoted as saying, excuse me, the funding model is inadequate. How short of money is it?
Well, obviously, 4 or 5 years ago when this was established, this was a new program, so it had to be road tested. And what we've learned is that the average Headspace centre really costs about $700,000 or $800,000 a year on average. There's a bit of variation there to run. Now, currently, we're only allocated about $450,000 a year to finance it, so it's really short. So we can't recruit enough providers. We can't actually fund the assertive outreach and community awareness elements, so it's cash-strapped. A modest investment to strengthen it would go a very long way to making it accessible to many thousands more Australians. And that has to be done in parallel with the rollout of new centres. We must be financed for both tasks, not just one.
What has to happen now? Nicola Roxon was on Radio National this morning saying mental health will be a significant second-term agenda. She's also, I think, in her remarks on PM last night and again on the ABC this morning, indicated that their broader reforms are helping the mentally ill. So in both those messages, I hear not now, later. Why do you say it has to be now, and what can we do to try and make it now?
Well, we've heard that so many times before, just you're the next cab off the rank. But it's a case of scraps from the table. If we do wait, if we don't actually start building the system and investing in it right now, many thousands of lives will be lost over the next few years, preventable deaths, and also tens of thousands of people will head down the track for disability. This is preventable. We have really good data now to show that, as Carla was saying, getting on top of the problem early changes the course of these mental health problems and saves lives. So that's the cost of not doing it right now. The idea that we've got to somehow, quote, get the fundamentals right, that logic wasn't applied to acute health. We need to work now. There are programs right now like the ones we're mentioning today, Headspace and EPIC, that can be scaled up around Australia. They've been done in other countries, the early psychosis model across whole nations. There's no excuse for delay here.
Would you please give Patrick McGorry a round of applause? For Ian Hickie. And I welcome now Professor Ian Hickie from the Brain and Mind Research Institute at the University of Sydney. We spoke again earlier, and you said the community is smart and the health system is dumb. What do you mean, and how is it relevant to this conversation?
Well, as Pat just alluded to, the advocacy around Headspace goes back, if anyone can remember this, prior to the 2004 election. And work the Mental Health Council and others had done, and myself and Pat with John Howard at that stage, going trot around Tony Abbott, who wasn't that interested, to the Prime Minister, who actually was very interested, in association with other people, Trish Worth and subsequent Christopher Pine, to get Headspace up, right? 2004, to say, look, early intervention, as in all other areas, cancer people best understand. I'm very glad to see Jim Bishop, our Chief Medical Officer and architect of our regional cancer plans. They're not now, they're right now. They're not waiting. They've got the evidence base, they scale up, they do. We had a discussion back in the early part of this century that youth mental health is important because it is where early intervention can occur. These problems start in young people. The health system is not designed for that age group. The great primary care initiatives and the work that's done in primary care is largely done from ages of 28 in women and about 40 in men upwards. It doesn't connect with that group of the population that gets unwell at this particular point. It's not in the childhood years either. Our health systems are built around 19th and earlier 20th century demographics. This is a 21st century problem. The Howard government, of all governments, understood that 2004. We're now in 2010. Has the health system changed? No. Primary care systems are very rigid and very fixed. Acute care systems are very fixed. We went through the whole nonsense of the Health Reform Commission to get out and say, okay, this time we're going to get serious. We're going to update our health system to 21st century. Came out with all the recommendations. What happened? Mr. Rudd put that aside, did his own listening tour in acute hospitals, open regional cancer centres, more surgical waiting lists, more emphasis on beds in the acute sector, actually ignoring the evidence. So the community is smart, the expert evidence is there. We wouldn't say in cancer care, look, you can have it in Sydney, but you can't have it in Brisbane. You know, we wouldn't say we're not going to have regional cancer centres. We just don't say for other key areas, I'm sorry, you miss out. In this area, we have had Headspace now on the drawing board and in early development since 2004. And as of yesterday, the Prime Minister, stepping into an area clearly the Rudd government has messed up to fix it, goes straight back to the plan that ignores fundamentally something from 2004. So we don't change. We, the health system, are so rigid and fixed. We resist reform more than the community.
I'll just pause you there for a second, because I guess what I want is a quick diagnosis of why this change is so hard. I'm sure I'm not the only person in the room who's heard Ian Hickie speak many times on this with passion. We hear that when you actually get in the rooms with the leaders of various governments, they do seem to get it. And yet the change is so slow. So very briefly, your analysis of why it's so slow.
Health systems don't change. Doctors don't change. Professionals don't change. We go to work every day in the offices we work in, the systems we work in, and we do what those things are established and funded to do.
So the problem is not the politicians, it's the leadership in the health system?
Well, there are two levels. There's a very good monograph, if anyone wants to read it, by the Institute of Medicine in the United States. Governments have got to purchase the service you want. If you want to have regional cancer centres, you want to have different kind of primary care, the drivers, the financials have to be different. But the professions have to say, now, wait a second. We're not doing mastectomy on everybody every more. We're actually going to have 21st century treatments for breast cancer. You know, the professions themselves have to change and say, as Pat has done and other leaders in the areas, this is a world-leading model. I've just had the pleasure of going around the world again. Pat's model is being rolled out everywhere else in the world, in the developed world, except here. You know, in Australia,
Ian,
we're going to stick with the same rigid system.
I wouldn't normally say something like this, but because I'm in Canberra, I will. He sounds like he's arguing for federally tied funding grants. Is that what that sounded to you? Do you know what I'm saying?
You're saying federal, it's our money. It's our taxpayer money. I think we expect our taxpayer money to purchase the best available services on behalf of Australian citizens. Now that Tony Abbott's freed of being the health minister, he's turned around and said, of course, we should have one level of funding that takes all of our taxpayer money and goes out and buys the best available care.
But when you say it goes out and buys, are you saying that funders need to be more directive to the leadership of health services about what they can use the money for as a way of driving change in what you've called an inflexible health system?
Absolutely. Absolutely. The funders have a primary responsibility to go out in consultation, and it's why we've got leaders like Jim Bishop and others who've done this with state and national cancer plans. Here's what's required. How do we line the funding up to get the service delivery models? If you just wait for your own doctor, your own GP, your own hospital to change, forget it. They go to work every day and do what they were doing yesterday or last year or 10 years ago or 20 years ago. We all know that actually introducing changes in the health system is very hard. In mental health, no system was ever set up for the people in need, the key demographic that Carl was describing, to make it easy to get in, and then to have the specialist services immediately available. Cancer care is a good analogy. We need everyone to pick up a breast lump. The moment it's clearly a cancer, we need to get the immediate specialist service you need, and if it gets worse, the more complex services you need after that. It's not just a general practice thing, it's about the right treatments for the right level of problem.
We've heard, thank you so much. A round of applause, please, for Ian Hickie. Ladies and gentlemen, I'm managing time because I need to wrap this up at 9:35 because a number of people in this room have to go to an NH and MRC gathering around mental health. And I'm keen to give an audience opportunity here, and then I'll come back to our other panel members. I guess I'm most interested to hear from, and of course you can ask any question or make any comment you wish, but I'm very keen to hear from people in this room, what do you see as the priorities for action right now during this election period to get the key messages of what needs to be done for young people in this country across to both our politicians and to our health leaders? We've heard some views from Patrick McGorry and Ian Hickie. What do you think? Who'd like to make a comment or ask a question, and I'll run to you with my little mic. Thank you. Do you mind just introducing yourself? I'll hold the mic. Your name and where you're from?
Philip Bell. I'm from Canberra. I'm a carer there, and I've on a number of government committees. But I noticed that what seemed to me what was happening with the health debate on the financial side is that each side of politics is scared to spend another dollar in case they're attacked. And I watched the way that COAG meeting sorted out all their expenditure on the rest of the health system, and nobody raised it because there was no state premier, I think, prepared to agitate. So the Commonwealth said, let's just sit on this, not spend a dollar, otherwise we'll be attacked by the other side of politics.
Look, thank you for that comment. Could I just come to Patrick McGorry for a second? Because it's my understanding that the coalition have said they're going to spend $1.5 billion, and they have particularly talked about Headspace, or I might be wrong there. Can you help us?
Yeah, they've definitely committed to a very specific, they've left a lot of things out, obviously, but they've committed to a very specific focus on youth and early intervention, which obviously we have to welcome, especially in today's context. But I think this gentleman's quite right. Suddenly, when mental health came into the focus, fiscal rectitude surfaced, and that's what we're struggling with. You're quite right. The government has cobbled together, 60 million a year for the next 4 years. Yesterday to give the appearance that something's being done, but they've been constrained by the financial situation now. The opposition felt that they had to carve that 1.5 billion out of the COAG package, and they've been criticised now for taking the money away from primary care and acute health. So that is the problem. When it comes to mental health term, money becomes an issue. Where it comes to border protection, wars in Afghanistan, or acute hospitals, then there's no limit on what money can be found.
So how can we change that?
Well, I think it's a public. You can see advocacy takes you so far, and even consumer advocacy takes you so far. But it has to be a mass demonstration by the public in Australia, I think, to change that. And John Brogden on Insight last night said something similar. He said there's a big change occurring. It's over the last few years, it's really changing quite palpably day to day, I think. And as Ian said, the public is way ahead of the political leaders on this issue. But the public have to make it a bit clearer, I think, probably through the ballot box.
A comment else, thank you. Do you want to rush towards me too, or will I wiggle into you? Everyone breathe in, I'm coming through. Do you mind just telling us your name and where you're from?
Yeah, my name is Claudia Mooney, and I'm a student at Narrabundah College, and I'm actually mentally ill myself, and so is my sister. My question is I've seen the Get Up campaign conducted by Patrick, talking about how you can't have health reform without mental health reform. Why do you think it is that the perception within politics and within some aspects of our community today is still very much that mental health is a separate issue to physical sort of health, and they can't sort of coexist together in funding?
Just before I come to Patrick, what do you think?
I think that mental health, the way it's been explained to me, is it's just the same as having, it's caused by chemical imbalances. It's exactly the same as having diabetes or cancer. It's just that much less is known about it. And I think there's an old stigma surrounding mental health. And I think more needs to be done, as a youth with mental illness, I think more needs to be done definitely to address the gap between the health services for adults and children.
Thank you so much. Thank you. Quick comment, Patrick?
Yeah, I'd like to thank you as well. Put it so beautifully. The way I've described it is that people experience a kind of medical apartheid, so that if you do go in, as Ian said, with a breast lump, the doors just swing open. But if you come back 6 months later and you're having an episode of depression or psychosis, it's much more difficult road to hoe, and your whole treatment experience will be different if you manage to get treatment at all. So we have got this huge problem, and it's a huge national problem, because mental health is more important actually than anything else, because it affects people in the prime of life. It affects people your age and moving into adulthood. So, you know, suicide's the biggest killer up to 40, but the biggest cause of disability up to the 40s is by far, 3 times as important as cancer and heart disease in that age group. So it's a form of national self-harm, you could say, to ignore it in the way that we are.
Anyone else from the audience, before I come to the rest of my panel, a question or a comment that you'd like to make now? Thank you. I'll just whiz up to you. Hello, do you want to introduce yourself?
Yes, I'm Jenny, and I'm a deputy principal at a college. I'd just like to confirm what others are saying. I think so many young people do not present anywhere with an issue because they just don't feel there is anywhere they can go. And I spend at least 50% of every day dealing with mental health.
Could you just flesh that out a little more and explain what you mean?
Well, often students present with all sorts of other problems, behavioural issues, violence, aggression, and really it comes down to a mental health issue, which they haven't been able to describe to anybody, or nobody has actually recognised.
And you said you're a school principal?
A deputy principal.
What's your dream? As if you're saying up to 50% of your time is connected to mental health issues, what would be your dream of what would be available to you and your students?
Well, I do use Headspace, so I think that's a terrific service. I just think in every senior college, for example, we need so many more people who we can recommend students to go and see, who are actually trained health specialists. I'm not.
I'll just pause you for a second. I normally confiscate mobiles that go off and give them to child protection workers in rural and remote Australia. I'll forgive this one because I forgot to make my announcement. Please turn yourself off unless it's a diabetic pump necessary to sustain life. Then I will accept rhythmic clicking. But I'm sorry, I'll just come back to the deputy principal.
Look, I'm not trained. I'm an education. I'm trained in education. I think I'm a very good listener. I enjoy trying to help students and do the best for them, but I'm not a trained specialist. In fact, I just wish I could go and get some training so I could perhaps fill the void. I guess that's what I'm saying. And I feel very inadequate in helping students, but I sit and listen and I think how cruel it is that their lives are so disrupted and they are just so incapable of finding a solution. And I know that all the health specialists are just so overrun with other people that so many just simply don't go anywhere. And I guess we're starting to see in society the result of that.
Thank you so much. Would you please give her a round of applause?
Julie, can I make a quick comment, a suggestion? I saw this fantastic program in Sydney at Macquarie Fields High School recently. It could be rolled out across the whole country at very little expense. It's called the Yellow Ribbon Program, and probably 30 or 40 senior high school students in that school had been trained in the sort of skills that the principal just mentioned, listening skills and mental health first aid. They wore a yellow ribbon around the school. It's like a peer mentoring sort of model, incredibly effective, and the kids just loved it. And there was a conduit to better care. So that's something that could be instituted at every high school or every school.
Thank you very much. I think we've had a clear plea and reinforced by our Deputy Principal there for youth-specific services, for training and support for educational staff, and also for peer support. So just some youth-specific issues there I'm trying to draw out as action points. If I could now please come to Professor Helen Christensen, who's the Director for the Mental Health, of the Centre for Mental Health Research here at the ANU. I've come to you partly because I know that one of the action points you want to talk about is work in schools. Could I just come to that first?
Yes, I think there's a lot that can be done in schools that currently isn't being done. I think there's evidence that a large number of prevention programs for anxiety and depression work. I think the concept of school clinics is something that used to happen when I was a kid.
What does it mean, and what would you like to see?
Well, I think we used to have our shots, all our prevention shots through schools. Schools are a very good place to capture young people. I think if we built up youth-friendly services within schools that link to Headspace, we'd be way ahead, because there are very many incidents that happen in schools. It's really a bit of a litmus test to kids' mental health.
In a way, that's an example, is it, of what they call a universal service, because it would be potentially available, accessible to all young people in Australia?
Yes, but I mean, we have to actually have the backup behind those sort of services, and I guess this is where more money needs to be spent as well. It's all very well to raise awareness about mental health, but to leave the carriage of the mental health services to teachers and to others within the school is really not reasonable. There's very little capability left in schools because teachers are already engaged in doing what they do.
Just before we come to some of your other, I guess, reforms that you would like to see, you're concerned that even though we've heard from Carla today of a very effective general practice response to her mental health issues, that quite often general practice doesn't work well for young people. Could you explain that?
Well, I think people first of all have to get to general practice. And general practice is designed for middle-aged people because it provides the sort of services that we're used to obtaining. More young people seek help through the internet than they do to a face-to-face counsellor. There are a range of other services that we could directly provide to young people using internet technologies and other sources of means of getting direct, immediate help to young people.
You're quite passionate about e-mental health, and in fact, like any good professor, she sent me a very interesting diagram before I came here today. And I know you're also passionate about evidence-based research. Help me understand more in a nitty-gritty way, what are some of the e-health options you'd like to see available for young people, and how much research have we got on it at the moment?
We have very good research that indicates that prevention programs work in the schools. For example, a program, one that we run, if you like, showed that we have a intention, the number of people needed to treat is 14 in order to prevent the development of a depressive episode. So in a boys' school, for example, you teach a program over 5 or 6 weeks and you prevent the development of depression in 2 young people. That is huge. I mean, we're all taking aspirin to prevent our cardiovascular risk.
We're all begging our doctors for statins.
Yes, exactly. And
that was a little one for the middle-aged in the room.
But the number needed to treat for that is 135. We're talking about effective programs which will prevent the development of these disorders within schools. So there are many range of things. We now have a range of e-health services that go from frontline education through things like Inspire, Headspace, so on. We have virtual clinics that are run by many of our colleagues around the country. These can also help. These are a direct way for young people who don't necessarily recognise that they have a mental health problem to get immediate response and help.
Helen, I've heard speakers from the Inspire Foundation who are passionate about helping young people, about preventing suicide, and very passionate about e-health. Quite often the room they speak to is predominantly over 50. A lot of women, although I don't know what the evidence is on women and men when it comes to e-capacity, but certainly I get the impression during question time that there's a skill deficit in the health sector around new technologies. Is that unfair? I'm just wondering, is that one of the barriers to getting what you want?
Actually, I don't agree with you. I think that the rate at which internet access and the use of the internet for information is increasing is the most rapid rise in that age group is the over 60s. So it's more that early adopters adopt when they're young, but as we get older, a lot more people are using it. So I'm not sure what the barriers are. These are new services, but they only came about because of a COAG decision, and they're only programmatic. They're not infrastructure, and there's no evidence that we know that they're actually going to continue.
You want to see national research centres of excellence dealing with young people and mental health. Tell us what you mean.
There were some recent statistics about how much NH and MRC money was provided to suicide prevention, actually, and I think the rates were, for the same number of people who die through suicide, the equivalents are skin cancer and car accidents. The amount of NH and MRC funding last year was 700,000 for suicide and 17 million for the other two. So we have this huge discrepancy between the burden and the cost of mental illness and the amount of research that's being put to it.
Can I just say, I'll come to you in one sec. My understanding is more people die from suicide each year than car accidents nationally. And I don't hand up, did you know that? So this is a very informed audience, because I don't think a lot of Australians realise that. I'm not sure how many politicians realise it, because that single fact, with then the differentials in funding, can be a powerful advocacy point. Ian, a comment?
Just on the key primary care issue, because one of Nicola Roxon's outs, and the government's outs, says that don't worry, primary care reform, health reform will fix mental health, particularly for young people. It is a nonsense. Just use the anecdotal. I now have 3 daughters living in Canberra, none of whom can access a GP in this major capital city. General capacity issues in general practice are big in Australia. General practice has done a very good job with improved mental health, particularly treatment of depression, for those aged 30 and upwards. All the new schemes, the big new better access schemes, psychological services, the beneficiaries are generally over the age of 30 because they get into primary care and they get into those systems. They're very good. They are not going to work for young people. We've done research for a decade about lack of access of young people through traditional primary care. And then even those who get in, the extent to which, in fact, they need much more than just primary care. They've got to be able to access the real services. So this nonsense argument the Minister has been putting out and continued as a Rudd government piece of rhetoric, trust us, Medicare locals, general reform, you'll be better off. All the evidence is in the youth area, it is not true. General practice is good for middle age, heart disease, continuing issues, families, and even there it struggles, and it does good work in mental health in that area. It will not work for youth area. We need youth-specific services. We've got a great model. We just need to roll it out. Just
before I come back to Helen, I want to ask you one more quick thing. You just said Nicola Roxon got it wrong. Yeah. In this next couple of weeks, in our advocacy for the sort of options that we're talking about here, do advocates and families need to come out blunt and fighting? Or do they need to be doing behind-the-scenes relationship building? What's the urgent tactic over this next few weeks? Because I'm assuming we agree this is a critical political moment.
I think I'm afraid to say, Julie, it might be the old Labor Party thing, vote early, vote often. Politicians do not believe...
I've got $1.5 billion on offer from Tony Abbott.
Politicians do not believe that people will vote on this issue. They believe they'll vote on cancer, they believe they'll vote on family doctors, they believe they'll vote on emergency department waiting times. Hence the this 4-hour waiting time thing in emergency departments. Ask anyone in the health system what that means. That isn't going to mean anything.
But are they right? They believe it. Are they right?
They're wrong. They're wrong, but this may be the occasion where people may have to seriously think about these issues. You see in the Get Up campaign, the number of people, particularly younger people, who are saying this is an issue they will vote on and is potentially an issue they will change their vote on. Politicians are very surprised. I think what we found through Get Up is actually people saying things that have been said in focus groups but now being said by 100,000 Australians on Get Up. And that is why the Prime Minister has done a smart thing. She's got involved because all the feedback is, geez, we've underestimated this. Now, if she'd asked John Howard, he would have told her, the focus groups told him that in 2004. Where we are world leading in Australia is changing community attitudes. Again, having just been around the world, the area we lead in is not health service reform. The area we lead in is the community attitudes. We've got the mental health thing right. But I think we're a very trusting bunch. We like these people. We think these nice professionals and these nice politicians, they'll sort it out. And frankly, in a lot of the acute healthcare system, whatever they do, in mental health, we've been let down. Your cab is coming. A bit like cabs in Canberra. It's coming. It never gets here.
Thank you, Ian. A fantastic analogy for locals. Helen, just before I come to our last panel member and then back to the audience, what flows is the need for new models of care. We've talked about e-health. We've talked about much more work in schools. Is there any other issue around new models of care, youth-specific models that you'd like to mention?
I strongly believe that the use of helplines and bringing evidence-based interventions into helplines is another new avenue which could be used well to reach young people.
And that funding yesterday, announced by Julia Gillard and Nicola Roxon, did go as a proportion of that to helplines.
It did, and I think that's very important, and I'm pleased to see that the community sector did get some recognition that this was a way ahead. However, it's not infrastructure support. It's not like building new services and keeping them there and linking them into health services, as, for example, health, if you introduce headspace centres and so on. It's programmatic funding, which is what people with new ideas survive on over 3-year funding periods. I think we have to get very serious about it rather than having the amount of money that's been put to it at this point.
Just finally from you, Helen, politically, you'd like to see a new cabinet minister for mental health federally, and also a mental health commissioner. Just very briefly, what do you mean by each of those and why?
I think mental health is so important for the health of our country. We actually need a cabinet minister responsible, rather than it being not core business for health departments, which I think we've seen it to be. And I think a commissioner is an important idea because it's like a watchdog over what's happening state and Commonwealth in terms of what's being rolled out for mental health.
Look, thank you so much. Would you please give Helen a round of applause? I come now to our host, Robert Wells, the Director of the Australian Primary Healthcare Research Institute and the Menzies Centre for Health Policy here at the ANU, and former First Assistant Secretary, Department of Health and Ageing. You've been in your former role, they reckon there's not enough leadership in the health system. They reckon it's rigid and inflexible. They reckon, you don't change fast enough. They need to tie your hands with specific grants. I'm surprised you didn't cross yourself. You're not Catholic.
Well, it used to be flexible.
But are they fair? Are they fair criticisms?
Look, I think they are to some extent. I must say, I think one of the real problems for mental health is that it's not a problem that the health system can solve, but we think the health system can solve it because we think health systems solve cancer, it solve whatever. But and we've heard this morning people. Part of their problem is not primarily a mental health problem in their perception. It's they've got nowhere to live, or they don't know where their next meal's coming from, or where they are live, it's not safe. They'll be abused or whatever. So, and the health system can't deal with that. The health system is just not capable of dealing with that. It's well beyond its reach. So we've tried to tackle mental health as a health problem, and then unfortunately we realised that and we gave it to COAG. Now, the best way to destroy any progress in this country is to give it to COAG, which is the Council of Australian Governments, and which is the body that's supposed to sort out the mess of federation in Australia, where we have different people funding, different people responsible for little bits of various parts of the system. And COAG has made an enormous mess of mental health. And people forget, and back to Ian's point, that in 2004, COAG actually put another $4 billion on the table. And even to today's terms, that's a lot of money. But where did that money go? Well, it seems to have gone nowhere, effectively, because 6 years later we're still saying we haven't fixed it. We haven't even tackled the problem.
In principle, the idea of everyone coming together around a table to get a unified national response sounds logical. In fact, I've heard people argue for it. What's the essence of your analysis of what COAG did incorrectly around mental health and what problem it's caused? What are you saying?
Okay, well, first of all, it didn't sort out accountability, and COAG can't sort out accountability because it is the Prime Minister and the Premiers and the Chief Ministers. So it can't just sort out accountability because no one's going to at that table say, okay, Kevin, you take it over for us, that's good, mate, and we'll give you all our resources or whatever. It doesn't work like that. So they haven't sorted out accountability. And then you get the problem of, back to World War II, which some people, none of us in this room I think could remember personally, but the convoy system, where the convoy had to move at the rate of the slowest ship. Convoys were a whole lot of ships together and they were safer against submarines. Well, in the federation system and with COAG, we all move at the pace of the slowest or the most recalcitrant of the states. And if a state really doesn't want to move, one state, and can be a very tiny state, doesn't want to move, the whole system doesn't move. And that's why I think we're finding we don't really have a national consensus at the political level what needs to be done in mental health to move it forward. And so we have bits and pieces of here and there, and some states move a little bit faster on their own, but it's not cohesive.
So again, we come back to this issue. We have a blueprint, but it's not being implemented.
Yeah.
It's piecemeal and sporadic.
Yeah.
What's how is it to be changed? What needs to be done?
Well, I'm interested in Helen's view that perhaps, and marrying it with Ian's view, perhaps the federal government should say, we will take over mental health. They've said we'll take over primary health care or sometime down the track, and we'll take over 60% of acute care sometime down the track. Well, why don't they say, we'll take over mental health. We will take responsibility for all the money that goes into mental health in this country, and we'll appoint a minister. And we will give the money to, not necessarily to state governments. You know, we will have a plethora now of local networks for this, that and the other thing. Well, let's make them work. If we're going to have them, let's say, okay, you're a group of people, you're accountable for this range of mental health services in your community. Here's a budget you can have, and you do the things that you think will work in your community. So if that means giving money to support counsellors in the local schools, that's what you can do. And if the body next door thinks it's more about doing something in other centres or outreach services, you can do that. You have to account back to us for some performance improvement in the mental health and access, etc., of your community. But we're not going to specify it has to be done this way or that way or whatever.
I just want to sum up what I've heard from you so far, because obviously I'll get a quick comment and then I'm going to come back to the floor. But I'm hearing a national takeover, a cabinet minister for mental health, and local funding with strong accountability mechanisms. But also I want to come back to your earlier remarks that it's not just about health. When we spoke beforehand, you said we need to have more emphasis on out-of-hospital care.
Yeah.
I suppose we've all heard about interagency cooperation, about whole of government. We know that. Desperately difficult to deliver in practice.
Yeah.
What are you looking for in terms of that, not seeing it simply as a health? What do you mean by that?
Well, look, I think, interagency cooperation is really hard, particularly at the central bureaucratic levels, because they're just not geared up. Their mindset, and I know it because I have the same mindset, or I had it, of course, is you don't think, you're much better now, I've been re-educated, but you think, what do I need to do what I have to do to account to my minister or the Senate committee that'll be quizzing me on what I'm doing? You couldn't give us, you're not really interested.
Sorry, but I funnily feel this last little bit is possibly the most important thing we've just heard. What you're describing is how your perspective on what needs to be done and what's a fair dinkum, fair thing. You can see I've been watching the debate. I just said fair dinkum. Sorry. But you're saying your perspective has changed because you've moved from being a senior federal public servant to now the head of an independent institute looking at policy. What's the lesson of that remark? Because we know that's true. Do senior leaders need to be rotated through sectors in some sort of formal way for this problem to be solved? Or otherwise, will this young woman be sitting here at my age saying these things? And I don't want to be depressive because I'm not depressive, I'm an optimist. But you know what I mean.
Yeah.
How do we change that narrow focus of the bureaucrat to their minister, which is becoming ever more desperate?
Yes. Well, I'm not quite, I think that's a really big problem to tackle because modern theory about public administration, etc., actually moves in the direction of you're more focused on the requirements of your minister rather than on some broader public good. So just leaving that aside, what I would do here and now in the practical world of Australia, I would bypass most of that. I would say, okay, well, health or housing or whatever, the bureaucratic silo. You do your thing. You work out get the evidence, etc., for the sort of broad programs. But we're sort of now, if you like, encumbered with a whole array of networks. Whatever the outcome of this election, we will have local hospital boards or local hospital networks and Medicare locals and aged care networks. Okay, I think they're a bureaucratic, or could be a bureaucratic overlay. But if we're going to have them, let's say, well, what are they going to do? Are they just going to be sort of someone we can blame when something goes wrong? So we've multiplied the blame game by 300 or something. Or can they actually move their local community? If they had a budget, could they go to the local branch of, New South Wales Community Service and say, well, look, we actually need in this area X, Y, Z. And here's why we need that. And this is how we think. And they can buy that off New South Wales Community Health or or New South Wales Housing, or whatever,
You're
wherever it
wanting
needs to come
strong
from.
local autonomy and strong local accountability.
But accountability and clear accountability, not just mouthpiece type accountability.
What I'll do, thank you so much. Would you please give Robert Wells a round of applause? I've only got about 7 minutes left before I need to wrap up. I want to get a quick comment, if I may, from Patrick McGorry, because he talks to big people and we need to know what he's thinking. And then I want to hear your comments on what most urgently needs to be done. Thank you.
Thanks. Look, I agree very much with what Helen and Robert have just been saying. We do need a mental health minister, I think. There needs to be a cabinet minister, and to be able to deal with that silo issue that Robert was talking about. I do think that the health issue is a core part of it, though. I know that we have very effective treatments. If they're not actually delivered, then all of the other things won't work either. But there's things like supportive housing, the vocational recovery programs, and all the other things that Robert was mentioning have to be brought into the mix. That can only happen if you have a minister that's responsible for all of those issues, and all the funding sits with that minister. It's got to be a heavy hitter in government, like a Bill Shorten or someone like that, who sits in the cabinet and actually delivers it. So not part of the health portfolio. That would be a great way forward. Helen said the same thing. I don't agree that we should just let each little community design itself, because there are standardised models that have to be made available to all Australians. You wouldn't do that in cancer and say, well, we're going with natural therapies down there in Wollongong, but over here we're actually building surgery into the mix over here in Canberra. You've got to have evidence-based, enforceable sort of models and accountability in that level. So it's got to be a bit of a mix between those two things.
Could I ask you one more quick thing? In my experience, I do endless conferences and panels, and I hear again and again that when people have a mental health diagnosis, they are again and again excluded from the criteria of the housing service, the child protection service. Once you have that diagnosis, you can get excluded from a lot of mainstream services, which leads me to think mental health specific services to help people get well enough to blend, if I could talk in normal language, is critical.
Absolutely, Julie. And I saw a fantastic example just down the road here about 3 weeks ago. There was the Home program in Queanbeyan, which was a local initiative. It was led by Peter Day, a local Catholic priest. He managed to get federal funding and a massive community support. There were 700 people at the opening of this facility for 20 beds, 20 normal units for people who had been homeless and mentally ill, and they had their own home for the first time for years. They were rescued from housing commission ghettos and from the streets and all sorts of places and put into this great facility. Could be done everywhere in Australia. Specific housing for people who are vulnerable and have mental illness. This is chronic mental illness. We need stepping stones like that for young people, because most of the homeless mentally ill are young these days, surprisingly enough. So we need these more specific services, which can only be done, as Robert was saying, if you've got a cross silo sort of mentality, and also authority, and a real budget.
Look, thank you. In a moment, Carla, I'm going to come to you and ask you, the single most important thing or useful thing you've heard today that you'd just like to underline. But before I do, is there anyone who'd like to make any comment you like, but particularly what you see as the priority right now? Thank you. Do you want to just introduce yourself?
John Goss, Health Economist, University of Canberra. It's really a question about the Headspace centres. There's 30 existing. The government are promising 30 extra. The coalition are promising 60 extra Headspace. Do we have the mental health workforce to go from 30 to 90 Headspace centres in the next few years?
Patrick, are you best?
Yeah, that's a great question. I think we do. We're just not competitive to able to attract it at the moment with the current financial model of Headspace. So I know that there are people that would come and work in Headspaces if there was the right financial model to give them incentive, and I think it can be done. Obviously, there's a training issue. We've got a youth mental health conference in Melbourne on Thursday and Friday. We're growing a professional field here over the next few years, so we have to actually create more skills and workforce. That's a work in progress, but it's part of the equation, as you say.
Just very quickly, Ian.
That workforce question is such a furphy used by governments. The Better Access Scheme was put out there, new money for psychologists to provide services. Guess what? It's oversubscribed, hundreds of millions of dollars. The workforce is there if the funding system is there, and they will preferentially come and work in this population if they can be funded. We're getting killed on the funding level not the workforce level.
Thank you. I've got another question here. Do you want to introduce yourself?
I'm Michael Moore. I'm the CEO of the Public Health Association of Australia. Excuse me. One of the frustrations for me, whilst I recognise that the focus today is about youth and mental health, and you've gone out a bit broader and talked to housing and education, but you know, comorbidity on drug and alcohol hasn't even been mentioned. And if we were to have a minister with just responsibility for mental health, where does drug and alcohol fit? And of course, they are administrative things that can be sorted. It's not impossible.
What do you think?
But and I think that whatever our consideration is, that when you're talking mental health, and particularly with young people, that a really major factor is drug and alcohol.
Thank you. A quick comment from Patrick, if I may.
That's absolutely
Use the
right.
microphone, please.
Oh, sorry. Thanks for bringing it up. Drug and alcohol is part of Headspace. It's integrated, and it should be integrated within any specialist youth mental health service. And we should actually, as you say, put drug and alcohol in with that ministry that we're just talking about. Thanks for bringing it up.
We have someone here. Do you want to introduce yourself?
Hi, my name's Sarah Blackledge. I'm a former drug rep. What would you say, I mean, I used to promote a cervical cancer vaccine, and before it was federally funded, it was about $450 for a course of 3 shots, which is very time-limited, specific, and had obvious benefits for a woman's entire lifetime to potentially prevent cancer. Now, with mental health, I think a lot of institutions, governments see it as a very ongoing, sort of never-ending issue. Like, if we fund it, oh God, what are we getting ourselves in for? And also talking about evidence base, the doctors that I used to speak with, GPs, as a drug rep, would say, oh look, I'm not going to promote that to my patients because I think they've got better things to spend their money on. It's too expensive, not worth it, and they would really take that sort of patriarchal approach, and very patronising I thought, and make the decisions for their patients without even discussing it. So yeah, funding is definitely going to be a big issue, but how do you think we can sort of at least get people in the door for a first consultation, or starting to get some mental health care?
Thank you.
Just very quickly, we've got really good data which has been gone through very carefully by Access Economics on 2 levels now, showing that if you don't invest in the early stages of these potentially serious illnesses, it's going to cost you a lot more down the track, both in direct healthcare costs and massively so in welfare and other lost taxation revenues. So it's a no-brainer. Early intervention is definitely a way of providing more cost-effective care in potentially serious mental illness.
And getting people through the door. I mean, I feel a number of the things that have been said so far, particularly in relation to schools, e-health initiatives, and the Headspace expansion, I think, go directly to that question in relation to young people. Do you want to introduce yourself?
Hi, I'm Terry Swarner. I'm a healthcare consumer advocate. In December 2009, a result of a study that showed out of 15,000 people surveyed that mental health was 73% the best or the top need of the healthcare and the healthcare rights system. And we launched the Australia Healthcare Right Charter. And we have this enshrined in law. And we have ombudsmen. And you all are advocates, and at this point in time you have not even mentioned this. And why aren't the advocates for mental health care sending letters from every one of their patients to this ombudsman to make the government do what it's supposed to do?
Look, thank you. Would anyone like to comment? Who's best? Ian?
We've worked with the Human Rights Commission Equal Opportunity nationally for a long period of time, and they've been right behind a series of national reports, right back to the Burdekin years in '93, through children in custody, through the not-for-service report in 2005. There is an issue about, is law one way to change politicians that's more effective than what they decide out of focus groups? And I think it is interesting. But this, in Australia, is a consequence of federation. Ombudsmen and sets of rights vary a great deal from state to state. The ACT is quite different to other places. So there are issues we have discussed with the Human Rights Commissioners nationally. To work, their view is for this to work very well nationally, the relationship between our human rights style in Australia and the Federal Attorney General is critical. I agree with you. I think it's an underutilised strategy, that this is a right, not just a need.
What I'll do, if you could pass the microphone to Carla, just tell us, what do we need to know? I haven't got time for an answer, but what do we need to know?
Well, the first of all, the Australian Healthcare Charter of Rights is a government legislated rights for every individual to have basically the best medical care in the world. And it's based, the ACT has its own charter. No other state has this charter. It's a federal charter, and it's not being used.
Thank you very much for saying that. Thank you. And I know we can all Google, thank God, and always follow up what's said in the audience. Ladies and gentlemen, I'm just managing our time and we only have a few moments left, but I wanted to come back to Carla Frost, our consumer advocate from Origin Youth Health, because this is a young woman obviously who's in contact constantly with young people dealing with mental health issues. I guess what has been most useful for you in what you've heard today, and what's the final message you'd like to leave us with?
I guess I'm not going to pretend that I really understand all the politics and budgets around it, but I just want to know that, you know, if I get unwell, a friend gets unwell, or a family member gets unwell, that I'm going to be able to walk in somewhere and get the best service that I need.
Thank you. Ladies and gentlemen, I'd just now like to hand over for closing remarks to Robert Wells, the Director of the Australian Primary Healthcare Research Institute, our host today. Thank you.
Look, thanks very much, Julie. First of all, look, I'd like to thank everyone for coming out on this, pleasant Canberra winter morning at such an early hour. We really do appreciate it, and thanks very much for your lively interaction. I'd particularly like to thank our panel, Carla, Patrick, Helen and Ian, for giving up their time to come here today and for sharing with us. And also very, very thanks to you, Julie. This has been a fantastic experience, and I'm sure getting us off to a great day and a great debate, and hopefully something will come out of this which will shift somebody, if not somebody's vote, somebody's allocation of dollars down the track. So thanks very much, everybody.
And can I just say finally, I spend my life often wishing people would utilise the media in a more sophisticated way. And this is a panel of people who really do use the media in a very sophisticated way in their advocacy, and it gives me great hope of more change in this area. So a final round of applause and we're finished now. Thank you.